Everyone. A warm welcome to our esteemed faculty for this next session now. I'm Dr. Varsha Jagtap, and I am an endocrinologist attached to the Nanath Mangeshkar Hospital. So, today we are going to be here discussing in this particular session about menopause and the link between menopause and the mind memory issues, the hormonal changes which take place around menopause, and also last session we'll be having on mind body medicine and oncology. So this session is basically about improving the health outcomes in menopause and menopause mind cancer interface. And the first session or the first talk in this session of ours is going to be by Dr. Professor Mala Dharmalingam. Yes, so Dr. Mala Dharmalingam is the director and the HOD of Department of Endocrinology, and she is a senior professor at MS Ramaiah Medical College and Hospital. She has got multiple awards to her credit, around 14 orations. She has published more than 134 articles in national and international journals, and she has got several textbooks to her credit. She is a very well-read speaker, and it is always a privilege to hear to her. So Professor Mala Dharmalingam is going to talk about hormones and mind and the cancer interlink at menopause. So can we have her talk?
A very good morning to everyone. I'm Dr. Mala Dharmalingam, and today we will be talking about hormones, cancer, menopause, and mind. What is the link between all of these? So let's start with the epidemiology of cancer and why we are worried about it. In 2020, globally, 19 million people were diagnosed, out of which 10 million died. In 2040, the speculation is that there will be 28 million people with cancer and the death rate would be 16 million. This is awfully a large number of cases and mortality. In the low and middle income countries like India, we account for 80% of the global cancer burden, while we have only 5% of the global spending to combat this disease. So therefore, we will continue to fall behind in efforts to provide quality cancer care to our citizens. The WHO has encouraged and strengthened the insertion, recognition, and use of traditional, complementary, and integrative medicine in national health systems at all levels, at primary health care, specialized care, and hospital care. And so that is what we will look at now. So what is the goal? The goal is, by the Sustainable Development Goal target for the year 2030, that we should decrease premature mortality by 1/3 from all NCDs, including cancer, compared to what it was in 2015. Now, countries with low human development index experience significantly higher premature mortality rates. One, because of delayed diagnosis, and two, because of access to therapeutic services is also limited, and also availability for treatment is also limited. The Society for Integrative Oncology has said to use lifestyle modification, mind and body therapies from different traditions in tandem with conventional cancer treatment. So this integration of conventional care and TCIM is called Integrative Oncology, which offer a bridge and a path forward to help deliver culturally sensitive, high quality care in low and middle income countries. So now let's look at hormones and cancer. What is the relationship? The commonest cancers worldwide are the endometrium, breast, and ovary. To look at the mechanism, just look to the right, and you would find that a high-fat diet, which is becoming so prevalent today, leads to obesity, which leads to insulin resistance. Now, what this does is it increases the pro-inflammatory cytokines, increases leptin, and decreases adiponectin. This causes long-term sequelae, increased risk of ovarian, endometrial, and breast cancers. So now if you look at obesity and see how it can lead to cancers, we know that the insulin has many receptors. So if the receptor pathway takes the MAP kinase pathway, then the chances of cell cycle progression and cancers could be much higher than if it takes the phosphatidylcholine inositol 3 kinase pathway. So now let's look at the hormones in particular. Now let's look at estrogen. What role does it have in the HB axis, adrenal and gonads? Estrogens have a marked effect on cell division in the endometrium. The estrogens stimulate mitosis, whereas progestogens actually oppose this effect. What about endometrial cancer? The late menopause, estrogen replacement therapy, and obesity, all of which we know is due to increased estrogen, can cause endometrial cancer, and these are the risk factors. However, on the breast, the epithelial cell division, the estrogen and progesterone both appear to stimulate mitosis. The effect at the uterine level is different, where only the estrogen causes mitosis and the progesterones are actually protective, while in the breast, the epithelial cell division is the mitosis is stimulated by both estrogen and progesterones. Now let's look at cortisol in the cancer mechanism. Many studies have looked at cortisol in breast cancers and other cancers. So what is the data so far? In the metastatic breast cancer, they have found flatter diurnal cortisol patterns than normal, and they feel that this may affect the expression of oncogenes such as breast cancer type 1 susceptibility protein, which is the BRCA1, and it could retard apoptosis of malignantly transformed cells. It causes also differential gluconeogenesis in normal and tumor tissue and activation of hormone receptors. And this glucocorticoid receptor hypersensitivity may also be related to cancers. Cytokine endocrine interactions are plausibly related to depression and adverse cancer outcomes. So we know there is a importance in cancer of management to look at the cause and the management. There's also another aspect. The word cancer itself connotes so many things for the common man, and immediately there are a lot of psychological problems that get associated, like depression. Now, this post-traumatic stress disorder, which is post-trauma, it could even be the trauma of being diagnosed with cancer, is also caused by glucocorticoid receptor resistance. So now let's look at a little bit about the mind and cancer. So now this was a very elegant study done very recently in Enhance, where they looked at 903 cancer patients. In regular OPD patients, they found that the psychiatric disorders were in 48%. But in cancer patients, the psychiatric disorders were in 53%. What were these? So they had adjustment disorders. The numbers, if you can see, the percentages are more because some of them had more than one problems. 44% had adjustment disorders, 22% had depressive disorders, 15% had sleep disorders, mixed anxiety depression was in 6%, and anxiety disorders was in 1%. So basically, most of them are having a psychological imbalance when it comes to cancer, its acceptance and management. Now, what is the reason for depression? It could be various reasons. Some of this speculated are the disease process directly. The disease process of cancer itself can lead to depression. The chemotherapeutic agents used can cause depression, and the person experiencing functional disabilities can also cause depression. So why I have put this is it's a very important aspect that we should not forget when we are treating people, especially with NCDs, be it cancer or even in fact diabetes. So now how to approach this, how to approach the integrated oncology of mind and treatment. So there are three spokes to this. You have cancer treatment, which is the conventional treatment. You need resources, you need trust. And however, in ours, it may be a fragmented care. They may come, they may not come. And then we have evidence-based screening, which requires a lot of education, infrastructure, and policy by the governmental agencies, where they say, okay, this screening has to be done at this age. Because for us, everything is spent out of pocket. This may not happen all the time. Now, what about palliative and survivorship care? It is totally underutilized in clinical practice or may not even exist in some countries for want of financial support. So now the balance between this is TCIM and conventional medicine. What does conventional medicines do? Clinical trial based, disease focused, single target, and you fight the disease. So that's the philosophy. The treatment they offer is surgery, chemotherapy, radiotherapy, hormonal therapy, and immunotherapy. While TCIM, the physiology of it or the philosophy of it is practice experience. There may not be any clinical trials, and if they are, they're small, patient-centered, multiple symptoms, and harmonizing. The treatment could be herbal medicines, acupuncture, touch therapy, movement therapy, and spiritual practices. So let's look nearer home, and we have Ayush, which is integration of mind and body, such as acupuncture, meditation, massage therapy, and yoga. They have shown an increased evidence base for improving symptom management during treatment and survivorship. The pluralistic healthcare system of India offers access to patients to TCIM, known here as Ayush, which is Ayurveda, Yoga, Naturopathy, Unani, Siddha, and Homeopathy. So the published estimates of TCIM use among patients who have cancer in India ranges somewhere between 24 to 39%. Now let's look at different modalities and what is the data from them. Let's start first with acupuncture. This is basically to control pain in patients who have cancer. A meta-analysis showed that a moderate evidence existed that breast cancer survivors on aromatase inhibitors reduced joint pain by use of acupuncture compared to their standard of care by 60 versus 30%. So they almost double the patients had a better joint pain cure or a better pain reduction compared to standard of care. So now let's look at another RCT where there were 360 cancer survivors with chronic musculoskeletal pain, and they found that both electroacupuncture and auricular acupuncture reduced pain severity by 1.9 and 1.6 points, respectively, on the brief pain inventory. It also reduced hot flashes when it was compared to gabapentin and venlafaxine, and both the Surgical Institute of Oncology and the AS American Society of Clinical Oncology and NCCN clinical practice guidelines have recommended acupuncture among options for the treatment of chemotherapy-induced nausea, vomiting, and pain management. So now the next therapy is massage therapy. So what does this have to offer us, and what is this? The application of touch therapy to muscles and connective tissue is called massage therapy. This was studied in patients who were on chemo infusion, around about 380 patients. And what they found was it reduced fatigue, pain, nausea, and anxiety significantly and decreased depression, insomnia, and pain versus simple touch. And the differences between the first and the second was the standard of care therapy was 0.9 and 0.61, and both were statistically significant. Then they tested the Swedish massage therapy in 66 patients, and they found that was a reduction in cancer-related fatigue, about 16 points in the multidimensional fatigue inventory. Breast cancer patients, they found that the manual lymphatic drainage massage reduced lymphedema and prevented secondary lymphedema. The American Society of Clinical Oncology has endorsed massage guidelines for managing depression, mood disorders, and NCCN also says massage can be used for pain and fatigue. So now let's come to the more commonly done and talked about one of the TCIMs is meditation. What is meditation? Mindfulness-based intervention like meditation focus. Now, randomized trials have shown that meditation is effective for reducing anxiety, depression, fear of recurrence and fatigue in patients who have breast cancer. It improves sleep, quality of life, and psychosocial adjustment. There was an RCT done in breast cancer survivors, 322, where it improves symptoms of anxiety, fear of recurrence, and fatigue. In another RCT of 271 breast cancer survivors, compared with supportive expressive group therapy and a one-day stress management control group, the mindfulness-based cancer recovery group significantly reduced stress symptoms and improved quality of life and social support. So now another very important area is yoga, and let's see how this improves the care in cancer patients. It helps promote stress reduction, a sense of well-being, restful sleep, and better quality of life in patients with recently diagnosed cancer, as well as survivors, improves social functioning and psychological symptoms, and reduces stress. There was an RCT done in 200 breast cancer patients for 12 weeks, and they found that 12-week yoga classes experienced a reduction in fatigue, about 5.4 versus 12.4 on a multidimensional fatigue symptom inventory short form, and increased vitality of 58 versus 51% on the energy fatigue vitality scale from medical outcome study. So at a 3-month post-treatment visit. So again, both the SIO and the ASCO have given guidelines that indicate that yoga may be considered to manage depression, anxiety, mood disturbances, and to decrease stress and enhance overall quality of life. The NCCN guidelines also says yoga may be considered for improving survivorship issues such as distress, cognitive functioning, menopausal symptoms, pain, cancer-related fatigue, and anticipatory nausea and vomiting. So now if I have to say the collaboration of conventional versus the integrated medicine and TCIM, so we would say that the conventional integrated oncology research would say develop, test TCIM intervention to address cancer symptoms and treatment-related adverse effects. And in the TCIM, cancer control workforce should have educate and integrate TCIM providers to promote risk reduction, culturally salient health lifestyles. And palliative and survivorship care implement culturally appropriate evidence-based TCIM interventions so that cancer patients of all cultures can live with respect, dignity, and vitality. So Integrative Oncology is an organization of working group to address issues surrounding integrative oncology, especially to strengthen research and training in low and middle income countries. And the WHO has worked with individual member nations to develop technical reports on the current state of TCIM, how to deliver, and how to propose solution to foster integration of care between the conventional and the alternate medicine of mind and body. So the TCIM practices to be integrated into the mainstream health system. That is what the WHO recommends in WHO 2013 to prevent cancer, early detection, and survivorship and palliative care. So with this, the low and middle income countries could provide affordable and equitable access to safe and effective services for patients affected by cancer, and have rigorous preclinical, translational, clinical, and health services research, spans the cancer continuum, aims at forming a robust TCIM evidence base, and helps reduce cancer burden. Government funding entities assist in the advancement of integrative oncology by supporting research, training, and mentoring, and incentivize research collaboration in both the TCIM, like yoga, meditation, and the conventional medicine to get evidence-based research to say that this is useful. So the interprofessional education also to be fostered so that TCIM and conventional medical professionals can work together to care for people affected by cancer. And this is very, very few and in between. There is apparently just one center in Pune who's actually looking at both the care, and this is what the WHO data says. So evidence-informed, culturally appropriate, and resource-aware clinical guidelines to be developed and adopted to improve quality of integrative oncology care. So to end, I'll talk about this, which is from China. It was recently published in 2021 in British Medical Journal. And this is called the Qigong Mind Body Program for cancer givers. That means cancer patient caretakers, their family and their friends. So this was a 3-arm pilot study. And what they did was a 12-week. So it was a community-based Qigong or internet-based Qigong or a self-care control group. They were, depending on their accessibility, whether they could come or not come, they were divided, they could enter any of these 3 pilot arms. And what was the aim? To modify intervention content for online delivery. They evaluate the feasibility and recruiting and retaining cancer givers into 12-week clinical trial and evaluate the feasibility of collecting and managing data, and a 6-month follow-up to assess long-term changes in quality of life. So it's very important that the cancer patients who are taken care of by their friends or family also may be going through so much of psychological problem, and whether they are aware what happens to patients and how to look after them. So it was very interesting when they saw this was after the training, they looked at what happens to patients, and they found the interoceptive awareness reduced significantly. The psychosocial anxiety, perceived stress, depression also reduced. The quality of life improved as far as emotional well-being, social well-being, breast cancer symptoms, and functional well-being. Physical, looking at grip strength, fatigue, both the left and right shoulder arm rotation movement, and pain interference. So if you have to look at it in a very practical way, this is how we usually learn to look at values, longitudinal linear graph. You find that whether you're looking at pain or you're looking at perceived stress, physical well-being, pain interference and fatigue, everything reduced except physical well-being improved, and they were all statistically significant, as you can see here. So this is a modality that is used in China, just like how we use yoga, and they found that this is very useful in their societies. So to conclude, the prevalence of cancer is rapidly increasing. The care needs to be integrative, both conventional medicine and traditional medicine. The treatment should aim not only at conventional care, but also pain and other psychological problems. The TCIM has shown improvement of patients in all the measures of psychological and pain control. Few medications in the Ayurvedic and Chinese system are also looking at treatment, and this whole integrative oncology will help treatment to be cost effective and improve the quality of life. I thank you very much. And this is a saying by a cancer survivor who says that everything can be changed. It can either be transfused or transplanted, except my mind is still mine. I thank the organizers for having given me this opportunity to be with you today. And I thank you very much for a patient hearing. Thank you.
Thank you, Mala Madam, for that excellent presentation. And I would also take this opportunity to thank you, Vaishalideshmukh ma'am. I mean, it is, very frequently that in our OPDs that we get asked these questions by our patients, doctor, so should I go for this acupuncture therapy? Doctor, should I go for this therapy? And then during our training days, we are never actually taught about these therapies. And so it was very nice of you to encompass and, put together all the literature that exists and bring these important points to us. Ma'am, may I ask a question?
Sure.
Yeah. So this is regarding, I mean, it's not exactly what your topic is today, but then as an endo, like we always come across patients who have, say, undergone, say, a hysterectomy for, say, some endometrial CA, and now the patient is complaining of severe hot flashes, and there is a restriction to the use of MHT. Then, what in your private practice? I mean, how do you actually approach these patients, and would you also incorporate some of these mind body techniques in managing these patients?
I personally believe that this is very crucial, that you should, even if you're giving some drug like venlafaxine or anything, this mind and body do play a huge role. So it's important that even if you're giving a medicine for that, you will have to counsel them to understand the consequences, and only then does it work to the best. Otherwise, you'll be finding that you're just giving so much of medicine and the person will not get the benefit that they want. So yes, I do incorporate this regularly for all my NCD patients. In fact, I feel the psychological problem is a very important problem that we need to, as endocrinologists, as you will also agree, that we have to do a lot of counseling. I always see a pinch of medicine and a lot of counseling goes into our practice.
Very rightly said, ma'am. Thank you. Thank you so much. Are there any other questions for Dr. Mala? Right. Thank you, ma'am. Thank you for being there. So,
Thank you.
thank you. So we will move on to our next presentation. Can we have the CV slide? Yes. So our next speaker for today is another senior endocrinologist, Dr. Usha Sriram. She has done her endocrinology training from Chicago, and she is currently an honorary professor of clinical medicine at Sri Ramchandra University, Porur, Chennai, and she also practices in Chennai. So she's an executive committee member of ISBMR of Indian Menopause Society. She has a keen clinical interest in women health and in gestational diabetes mellitus and in osteoporosis. So who not, I mean, a better speaker than her to speak on the mood and the menopause. So can we have a slides, please?
Good evening, everyone. I'm so delighted to be part of Synapse and Dr. Vaishali's conference, which is always a very, very special program. Thank you so much, Dr. Vaishali, for inviting me to speak on this, also this really important topic, which is what happens to the mind, the mood, and the memory at menopause, and a lot of questions that go along with it, especially pertaining to how does it, how does hormone replacement impact it, and what can women do, and what are the comorbidities, like, for example, obesity, that may have a serious impact on this as well. So on that note, really quickly, what is the menopause, the hormonal changes, physical and mental health at the menopause, both short and the long term, and is there a wellness program that can actually help the mind, memory, and the mood in terms of aging successfully and healthily? So menopause is, as we all know, is a very, very natural, and it's inevitable, happens to all women, and actually can be quite liberating in many ways. But menopausal symptoms, which affect a lot of women, but it's very variable, usually transient, and mostly manageable. But we will also talk about things that can be, quite distressing. So we know that there are a lot of cartoons and memes and other things. It's menopause can be, as they say, the butt of jokes. But for the woman who's going through that, and her family and her friends and colleagues, it can be a very, very difficult time. And especially what the issues that we are going to talk about today, which is, mood and memory, and what really worries women is this the beginning of a downhill trend? Is this going to be the way I'm going to be for the rest of the, my life? Is it all downhill from here? So as physicians, I think we really have a major responsibility to give them the facts, be reassuring, and be hopeful about things. So, and I like to begin with a joke, in the sense, do you see how menstruation, menopause, mental breakdowns, all of the women's problems begin with men? So one important thing is what has happened to life expectancy age at menopause. The age at menopause has remained fairly constant, around 50 odd years, 50.5 years for Western women, and typically around 47, 48 for Indian women. But our life expectancy, on the other hand, has increased dramatically, so much so that now women easily live into 80s and even 90s, so much so that they can spend as much as nearly half their life after the menopause. So now we see the importance of how postmenopausal health is so important. And menopause transition, which is about 4 years or so from before the menopause, it's a progressive endocrinologic continuum that takes reproductive age women from regular cyclic predictable menstruation that is characteristic of ovulatory cycle to a final menstrual period. And this phase can last, like I said, 4 years or a little longer. And as you can see, the estrogen levels going down and FSH going up. And FSH, we know, is the hallmark, or a rising FSH, or clearly having FSH levels above 30 is the hallmark of menopause. And many symptoms are attributable to menopause, typically vasomotor symptoms like hot flushes and sweating. It's associated with the changing estrogen levels and gonadotropins. Genitourinary syndrome of the menopause, typically it's a little later, a few years, usually about 10 years or so after the menopause, because of vaginal dryness and urethral passage dryness. Sleep disturbance, very common in menopause transition and early menopause. And this is something that maybe is associated along with the vasomotor symptoms, and can then lead to a lot of mood changes and memory issues and aches and pains and worsening of fibromyalgias, and even weight gain. And sexual dysfunction, it's partly due to lack of libido, partly due to the vaginal dryness. And then there may be other things, like I said, joint pains, mood and depression. Today we're going to talk about that. Many estrogen receptors in brain, and the declining levels of estrogen may be responsible for some of this. And then depression is also very common at this age, and cognitive dysfunction. So I'll start with a clinical scenario. A 51-year-old lady, high school teacher, last menstrual cycle was 9 months ago, has been forgetting names of old students and colleagues, long history of migraine, but very stable and migraine free, but more recently having more migraine, sleeping poorly with frequent waking up. And their cycles had been erratic even for a year prior to her long history of amenorrhea. And her last menstrual cycle, it says here, was 4 months ago, but actually it was 9 months ago. And she's told that this is due to her menopause. She feels stressed and wonders if it's all downhill from here. Like, am I going to be forgetting things and having more migraine and feeling miserable? So what are the things that are associated with cognitive impairment in peri and postmenopausal women? The estrogen decline can lead to sleep deficit, to depression, to hot flashes, and all of which can feed into cognitive impairment. And quickly, just to say that in 62% of women in the Seattle Midlife Women's Health Study, noticeable decline in cognitive performance during menopause, following the menopause. The most common complaints were difficulty recalling words or numbers, needing memory aids and forgetting why one was involved in a certain behavior. This can be very worrisome. But in a study that actually utilized a sample of 151 female faculty members between the ages of 30 and 60 years, large New York school district, they noted that peri and postmenopausal women were 3 times more likely to report memory complaints than were the premenopausal women. But unfortunately, in an excellent systematic literature review during which they examined the evidence for treatment using hormone therapy from 20 well-designed research trials, what they found was it was not effective at enhancing cognitive performance in 9 of these studies, all of which included samples consisting of older age women. And the findings were also replicated in 9 studies where samples comprised of midlife women. Therefore, it's likely that there are other factors at play and not just a decline of estrogen. So replacing the estrogen does not make a postmenopausal woman a premenopausal woman. So, and just to show you from the data from the Nurses' Health Study, lack of relationship between use of hormone therapy in non-dementia older women and cognitive function as determined by the telephone version. So, but the other thing that is a little bit concerning is risk of dementia with hormone therapy. So in the Women's Health Initiative, which we know turned the whole hormone therapy on its head, after a mean follow-up of 4 years, hormone therapy was actually associated with an increased risk of dementia. So just to keep in mind that many of these symptoms cannot be reversed with introduction of hormone therapy. But on the other hand, for example, what about sleep issues? Prevalence of hot flashes correlates with prevalence of insomnia. As I said, there are receptors in the brain for estrogen, and it's kind of like having a hot flash in the brain that there is this insomnia. And then menopausal women spend significantly longer time awake at night and have lower sleep efficiency. So all of this can also further contribute to mental, what we call the fog, the mental fogginess, issues with memory or irritability and mood changes. So this is something to keep in mind. So it may be associated with changes in memory and sleep. Sleep disturbance may increase migraine, seizure, and fibromyalgia frequency. And sleep aids or hormone therapy may be tried for a short time, but like I said, this is not the panacea. Postmenopausal cognitive decline has not been helped by hormone therapy. So if someone is having vasomotor symptoms or sleep disturbances, a short-term trial of hormone therapy or something like venlafaxine may help, but not for a long-term therapy. What happens to body and weight composition changes? We know that there are clinical issues of one of the issues is body composition change and fat distribution. An average weight gain seems to be around 2 to 2.5 kilos or 5 pounds, but it's more of central fat distribution. And the weight gain is associated with metabolic syndrome and hot flashes, sleep deprivation, and a sedentary lifestyle, and a decrease in muscle mass. So again, stressing the importance of resistance training. But what does weight gain do to the brain? Obesity shrinks the brain, associated with reduced brain volume, slows cognitive function, and brains of overweight and obese individuals appeared 8 and 16 years older, respectively. So, but the important thing to remember is what is positive about the menopause. From pause to power play, meaning women who have gone through the menopause, they may have better power of purpose, power of judgment, power of contentment, and power of lived experience. And all of these are important for us to stress to our women who are going through the menopause. with the power of wisdom. The middle-aged brain has developed powerful systems that cut through the intricacies of complex problems to find concrete answers. It more calmly manages emotions and information, more nimble, more flexible, even cheerier. So on 4 of 6 key mental abilities, the peak actually comes in midlife. It can size up situations better, draw the connections, and see the wider context. This enables better judgment if it appreciates subtlety and ambivalence. So in a research on wisdom, what it is and who has it, one study concluded it peaks at about 65. So there's hope after a sustained accumulation through midlife. So myelin, the crucial white fatty coating of the nerve fibers, makes the connections in the brain work. In 2 key areas of the brain, myelin continues to increase well into middle age, peaking at 50 on an average, often continuing to grow past 60. So very important. Now comes the mind. This element, or a complex of elements in an individual that feels, perceives, thinks, wills, and especially reasoning. So, which is why we use these expressions: state of mind, out of our mind, mindful of behavior, mind over matter, mindlessly busy. You get the picture. So we use mind in this, context. So now coming to menopause itself, first thing is your hormones can't decide if they're coming or going, meaning, there's like so much of fluctuation. Emotional health is intimately linked to our hormones. The female hormones, estrogen and progesterone, interact with brain neurotransmitters such as serotonin and GABA. Both of these brain neurochemicals are implicated in depression, PMS, and anxiety reactions. Now, next thing is this insomnia, tossing and turning. And what does that do? Increases sleep apnea, increases prevalence of sleep apnea. Postmenopausal women had significantly higher AHI, was sleep apnea, compared to premenopausal subjects. So this is something that we should absolutely keep in mind and ask our patients about snoring and sleep disturbances and daytime somnolence. And most women have trouble sleeping in midlife. In fact, as much as 61% of postmenopausal women report insomnia symptoms, according to the National Sleep Foundation. Estrogen and progesterone help protect younger women from what we think of as male breathing disorders, such as sleep apnea and snoring. But as these hormones wane, they become more susceptible. Women become more susceptible to these sleep disrupting problems. And we also know that OSA itself could be a risk factor for cardiovascular disease. Now, this is important, and why I built up all this about sleep apnea is less brain volume in patients with sleep apnea. So we need to do things that actually improves, brain health. So effects of hormone therapy on cognition and mood. So this also has been looked at. Only beneficial mood effects with small amount, medium ESs were noted with the 4 years of conjugated equine estrogen oral, so the generalizability of these findings is limited. So the other thing is, many women find it difficult to hard to get older, meaning changes in the body that is happening, or what is happening, in terms of their mood and memory and cognition, and also just the family situation. There may be a lot of self-pity, self-doubt, so this is a important area for us physicians to also be supportive and give them the facts. So every day people notice maybe a new wrinkle, they may be gaining weight despite working out harder than ever, and some hair growth, thanks to changes in the hormones. And the children who may be teenagers or older, and maybe, they have their own life, and spouse may also be going through a midlife crisis of sorts, and parents who are older and maybe having health issues. So there are a lot of other things that is happening in a woman's life around age 47 to 53, which is usually when they are going through the menopause. So it's not just hormonal changes, but other changes in the family structure and it is also happening. And like I said, elderly parents and caring for them can be a daunting task, making doctor's appointments, due to day-to-day errands, dealing with end-of-life issues sometimes, and still juggling their own household obligations. So, and women are now responsible for their parents while still caring for their own children. So this is something that one should be able to counsel our patients as well. So now coming to some of the symptoms. One of them is, of course, the vasomotor symptoms. Again, completely unpredictable, though we typically talk about it lasting for a year or two. And there are women who have heat intolerance for the rest of their life after the menopause. So what has that got to do with cognitive symptoms? The worse the physical symptoms, worse the cognitive symptoms. So women with more hot flashes experience more cognitive deficits. The intensity of menopause symptoms is associated with more memory and attention complaints for longer durations. And therapies for vasomotor symptoms, besides the usual cooler rooms and cotton and loose clothes, plenty of hydration, doing yoga, meditation, mindfulness, venlafaxine is something that has been known to be quite helpful. And also for some women, hormone therapy is helpful in the shorter period of time. And it has to be, of course, gradually weaned off. I've come to the last part of my talk, which the most important part is what happens to the brain and how can we, make it, retrain it or regrow it. So stress shrinks the brain cells in the hippocampus. So why this is important is not, this ubiquitous stress and also depression. Risk for depression, especially higher in women with previous episodes of depression, with estrogen withdrawal therapy, and somatic symptoms, especially sleep disturbance, anxiety, sexual dysfunction, create actually a risk for depression as a downstream effect of all of that as well. And a life stage perspective, changing family or professional roles, which I already mentioned, interpersonal losses, aging, and physical illness. What does it do to the brain? The number of days of depression is associated with severity of hippocampal atrophy. Depression is associated with impaired memory, executive function, and processing speed. So now you can see why it's not just about estrogen. It's about so many other things, what depression is doing, what sleep is doing, what obesity is doing, what stress is doing to the brain. So when we talk about helping the women who are going through the menopause, especially from a mind, mood, memory perspective, we need to talk to them about eating healthy, exercising regularly, finding a self-calming skill to practice, such as yoga, meditation, regular breathing, mindfulness, avoiding tranquilizers and alcohol, engaging in a creative outlet that fosters a sense of achievement, and stay connected with family and community, nurture relationships and friendships, practice mindfulness, tailored short-term hormone therapy for those with severe vasomotor symptoms, premature menopause, or surgical menopause where there is an abrupt drop in the estrogen levels. But the Women's Health Initiative told us it does not only not help cardiovascular disease over a period of time, there may be increased risk of heart disease, breast cancer after 4 years to 5 years of therapy, increased venous thromboembolic disorders. In unopposed estrogen, we know if one can get endometrial cancer. Where it did show benefit was in colorectal cancer, and it also showed benefit in terms of fractures. So it's really important for us to be able to individualize therapy when it comes to hormone therapy and not use it as a preventive prescription for healthy aging or a preventive prescription for cardiovascular wellness or anything like that. It has to be very tailored for symptomatic women with vasomotor symptoms, or if they have genitourinary atrophy, we could use topical estrogen. Now, the brain wellness program that I was talking about. So in the short term, what happens to the hippocampus, and in the long term, the brain cortex. So in this unique integrative approach, which I really am impressed with, first, there is a comprehensive diagnostics to evaluate brain health. That's what they do, a neurocognitive assessment, brain mapping, and basic blood tests, and sleep health assessment, cardiopulmonary testing. I'm talking about in the program. And what did they do? They basically asked them to do brain coaching, activities that stimulate the brain, exercise, cognitive skills and memory training, and progress monitoring, healthy eating. So if you really look at, take out the technology aspect, it's healthy eating, exercise, doing brain stimulating activities, and following all the wellness prescription that I talked about. Does it change what has happened to the brain? I want to show you something. So this is the hippocampus before, and this is the hippocampus after this wellness program. So if I have shown you some things that happen to the brain during the menopause and things that happen to women, and how this can be retrained and reoriented and regrown. So menopause is a natural part of every woman's life, with varied presentations from very smooth to turbulent. Attention to lifestyle and health conditions should be the approach to long-term wellness. Mental health is top priority, and everyone around should listen and not dismiss it as menopausal whining. And we as physicians must have a quick checklist to talk to patients about sleep and about weight and about what's going on in their life, what is their mood like, what's their memory like, and what kind of cognitive issues are they having, and sexual health. All of these things we do a quick assessment, and then we talk to them about this wellness program, and you could curate your own wellness program. So the mental health should be really top priority even for us. And the Menopause Society and healthcare professionals are the advocates for women throughout her lifespan, and especially at the menopause and postmenopausally healthy aging, building muscle, avoiding sarcopenia, avoiding heart disease, cancer screening, mental health wellness. These are the things, and bone health, preventing osteoporosis and fractures, fall prevention advice. These are the things that we need to do in terms of long-term care of women after the menopause. Thank you so much. And I'm happy to answer any questions.
Thank you, Dr. Usha, for the excellent presentation. For the paucity of time, we will move on to the last part of our this session. That's the discussion that is on mind, body medicine, and oncology. Can we have the CV slides of the speakers, please? So our speakers for this discussion are Dr. Chetan Deshmukh. He is a medical oncologist, is the first DM medical oncologist in Pune. He is consulting medical oncologist at the Nanath Mangeshkar Hospital and Orchids Breast Health, Jahangir Hospital and Ruby Hall Clinic, honorary at Sassoon General Hospital. And he is actively involved in clinical research for the past 15 years. And he is also the president of the Spear Society. Can I have the next slide? So our next discussion for today, we have psychiatrist Dr. Aarti Behel. So she is a consultant psychiatrist at Apollo BGS hospitals in Mysore since 2004. She has done her MBBS from Tanjavur, her MD psychiatry from KMC Manipal. And she has previously worked as assistant professor in Department of Psychiatry at KMC Manipal. She has got multiple papers which have been presented and also authored chapters into textbooks. And her special interest is mental disorders in women, OCD, and medical legal aspects of psychiatry. So over to you.
Thank you. Thanks a lot, Dr. Varsha, and thanks a lot, Dr. Vaishali, for having me here. I know Dr. Chetan needn't thank Dr. Vaishali, but I ought to, because she's been carrying this baton for almost 3 years now, 3 to 4 years, I think. And kudos to you, Dr. Vaishali.
So, yeah, thank you, Dr. Varsha, for the kind words of introduction, and welcome, Dr. Aarti, though virtually, to this meeting, the third Synapse 2022. I think I'll share the PowerPoint from my side. Will that be okay? Yeah, okay. Give me a minute. Yeah, are the slides visible now? I'll just make it full screen. Are the slides visible?
Yeah.
Yes, sir. Yes.
Yeah. Okay. Perfect. Perfect. So it was an interesting concept that the malignancy also needs to, even mind health also needs to be looked at in malignancy patients. Largely, most of our patients have in cancer, mind health was a neglected topic because the main problem was a body aspect. Most people were not able to survive or not able to receive proper treatment for a long period of time. And that is why the quantity of life itself was under question. Now that the quantity of life has improved, our treatments are getting better. It's not only chemotherapy and chemotherapy. There are many other things which can be done for cancer patients. And that is why now we are focusing on improving patients' quality of life, and their psychosocial issues play a major role in improving the quality of life. And that is why psycho-oncology actually is a very vast topic, and there are several aspects to it. There are several angles to it. But I thought we should make at least an attempt to get into this aspect of psychosocial oncology. And that is why this year's discussion happened. Tomorrow we are again going to have a separate session on oncology, but that will be largely related to endocrine practice. Here we are going to discuss a little bit about psycho-oncology. So, yeah, Dr. Aarti, I have had questions, so probably we'll start off with the questions in the interest of time. We are running short of time. We know that cancer treatment can cause a host of problems like actual physical pain, fatigue, and loss of autonomous life, anxiety, depression, and various aspects on various personal problems. So when we deal with it, when me as an oncologist, when I'm going to treat a patient with cancer, how often do I need to assess a patient for these psychological issues? Because every day I ask them the same question: do you have vomiting, do you have fever, do you have weakness, do you have pain, or something like that? But how often should I be asking them about their psychological well-being?
See, there are no guidelines as such which say that you have to screen them at the first visit, or followed by whenever the patient is being exposed to a new therapy or a new staging of disease. But according to the USA guidelines, they say that initially when the patient presents to you, and later on as and when it is required, they've said. But there's a lot of difference between India and the West.
Oh yes,
I'm sure that when a patient is diagnosed with cancer in the West, they take about at least a minimum of 1 to 2 months time to reach the oncologist, maybe more. I'm not aware. But in our setup, I think in India, the day the patient is diagnosed with a cancer, I'm sure he lands up in your OPD the very same day. So I don't think initial screening would be a relevant thing to do in an Indian setup. The day you diagnose a patient as cancer, I think obviously anyone would be stressed out, considering cancer, the stigma attached to it, or even the whatever worries that go on in a person's mind. So initially, I don't think it's a good time in India to screen, but definitely, we should give them some time to settle down with their worries, maybe about 6 weeks to 8 weeks time, and then screen them again for psychological problems. As and when the patient, progresses into the illness, probably, when you're changing therapy, or, you do a PET scan and you realize that the growth is, probably increasing, you need to tell the patient about it. I think, again, you should make mention of psychological problems, or, ask for psychological problems and see whether the patient responds to it. Many a times what happens is that, the patient expects these kind of questions from the treating physician. Unfortunately, we as clinicians, fail to either ask them or even recognize them. We think that, our problem only lies with vomiting and nausea, and that's the end of it. Maybe the patient is waiting to be asked. So I think this should come in everybody's training as a physician to, start asking patients for psychological problems.
Yeah, that's a very nice point, actually, because even our cancer guidelines, the one which is available in print, the National Comprehensive Cancer Network guidelines, have a concept of a distress thermometer. And it was published several years ago, almost 8 or 9 years ago. And they have this objective measure of a person's distress. And it is recommended that we should assess the patient periodically, as you rightly said, maybe not immediately on the day of diagnosis, because everybody is going to be distressed. But as therapy progresses, we need to know how they are feeling and how well they are taking treatment. And it goes a long way. Psychological counseling and even assessing their problem goes a long way in making sure that these patients even stick to treatment. Otherwise, these patients are likely to drop out of treatment if they feel that they are not taken care of properly, or they feel that nobody listens to them. Then these are the people who keep on doing shopping here and there. They'll probably shift from one hospital to the other, and the entire treatment is thrown into a big disarray. So factors which affect psychological functioning are, one is obviously the reaction to the diagnosis by patient and the family. In India, the reaction of the patient may be a little delayed. You rightly said that in the Western world, by the time the person reaches the oncologist, it's going to be a few days. In India, by the time a person knows about his diagnosis, it may be 2 or 3 chemotherapy cycles. Once they start losing their hair, they realize that, oh, well, there is something wrong, and they haven't been, this is not the regular treatment. So I'd like to pause here and let you, I wanted your inputs about how do we break this news. Nobody likes a diagnosis of cancer, and most people even break down in our OPDs when they hear about the word or even the possibility of a growth being malignant. So how do we break this news? One. Second, many of the relatives sometimes say that, well, we don't want our patients to know, which actually is not a very nice thing, because the patient is the one who's ultimately going to go through the troubles which either of the diagnosis or of the treatment. So how do we deal with this problem?
I think breaking bad news should be taught in our MBBS curriculum. Any chronic illness that we deal with, or
Hello? I think we've lost contact with Dr. Aarti. Can someone from the team please check whether Dr. Aarti is still online?
No, doctor, she's not.
Oh, she's not. Okay. So yeah, this is an important point which actually I wanted to discuss with Dr. Aarti, that how do we break bad news? And she rightly said that it is something which needs to be taught, not only about the diagnosis of cancer, but any bad news being thrown into somebody's face or being told in a very rude or a wrong manner can have a very deep and a very profound impact. Some of my patients have learned about their diagnosis while sitting in the OPD. Somebody is sitting next to them and casually asks them, oh, what is your stage of cancer? And then that is a time when it hits them that the problem which they've come to the hospital is cancer, and they are now going to see a cancer specialist. And that is a very tricky situation, because sometimes relatives want to shelter the patient from knowing the diagnosis. So we as oncologists are in a dilemma because of our OPD schedules, because of our other pressures. We really don't give enough time for a patient to sit down and explain it to them, or allow them their grief reaction to come out. And that is something which is going to take a little bit of training from for us, because breaking bad news is, we are not going to make that bad news good, but we should at least try to soften the impact. We should allow that person to go through the gamut of emotions which the person goes through. And that is a known thing, the Kubler-Ross phenomenon of denial, anger, bargaining, depression, and acceptance. We see this in our day-to-day practice quite often, that sometimes when the patient is told about diagnosis, the first reaction is denial. No, this is a wrong report. This is not my report. Maybe there is a mix-up at the laboratory about the specimens. That is the common reaction. Then some of our patients start complaining that, well, I had gone to this doctor a few years ago, but he never told me. Or usually there is some blame game, that I've been telling these people that I have this problem, but nobody showed me. That kind of anger reaction, or then getting angry with the hospital doctor and other people around them. Generally, their mood is foul for the first few days. That is the time when that anger effect sets in. And then they come down to my OPD for bargaining. That bargain is not necessarily financial. It is usually for the treatment, that, well, I will undergo surgery, but I won't undergo chemotherapy. Or maybe I'll just go through radiation, but no chemo. Or, okay, chemo, I'll take few chemos and then we'll see how things happen. This kind of bargaining happens quite often in our OPD. Then comes the phase of depression, when the person realizes that, well, no matter what he does, this thing is going to stay with him and he'll have to face it one way or the other. And then comes the phase of acceptance. Now, as an oncologist, let me be honest with you that we've seen some of the patients who get stuck in the first four stages as well. There are some people who continue to remain in denial for a very long time, and they keep on talking about getting second. There'll be probably 20 second opinions, and they won't stop till somebody tells them that, well, it's nothing wrong and it's just a simple problem. It will go away by doing some small treatment. Some people remain perpetually angry, and some people remain perpetually depressed. But these numbers are far and few. About 10 to 15% of my patients probably remain stuck in the first four phases. 80, 85 or 90% of the population finally comes to term with their diagnosis, and then they decide that, well, yes, this has happened and they need to take treatment. So, this is where we wanted Dr. Aarti to join in. Can we?
Yes, sir. She's joining in a moment. I can see.
Okay.
Can the technical people just give her the entry to the panelists, please? I can see her.
Yes.
Yeah, I'm back. I'm so sorry about the glitch. I always land up, I think. Yeah. So we were talking about breaking the bad news. Have you discussed that, Dr. Chetan?
Yeah, I discussed that, and I discussed about the 5 phases of grief as well. Another thing which we discussed also about the assessment of psychosocial problems. So, as a psychiatrist, how would you deal with these patients when they have got stuck up in one particular stage of grief? Somebody is perpetually in denial, or somebody is perpetually angry about his diagnosis, or keeps on bargaining about treatment and doesn't take correct treatment in time, or has remained depressed for a long period. So how do you deal with these?
See, sometimes all we have to do is just do active listening to these people. And we don't get answers to it in 1 or 2 sessions. We need to take at least 3 to 4 sessions for the patient to get comfortable with us. And then they come out with the kind of problems that, for which they're denying or which they're angry for. And then, they're trying to bargain with God, or trying to throw their anger on the doctor who has diagnosed them. also what we need to do is sometimes, as doctors, we ask them questions like, why are you feeling this way? If you could rephrase your questions as what makes you feel that way rather than why are you feeling that way, that would be more appropriate. If you ask them, why are you feeling this way? They'll say, why shouldn't I? Or, things like, I just don't know. But when you ask them questions like, what makes you feel that way? They come out with the real responses and they let you know that, my son's wedding is to be done and I have to run around a lot. And now I have been diagnosed with this breast cancer and you're telling me that I need to get operated on. How do I manage all these things? So then we come to know the real concerns that are lying behind their behavior.
So, we were discussing the other day about these things. So screening instruments, I don't see a lot of screening instruments being used in practice. But what about psychoeducation? So how do we tell a person, I'm sorry to say that I know a lot many psychiatrists are also here. They are probably listening to us, and there are some on the panel as well. A lot of people, when we tell them to meet a psychiatrist, the first reaction is, do you think I'm mad? That is a common stigma. So actually, I don't want the person to go to a psychiatrist for some psychiatric problem as such, but I need, if somebody can give him a patient hearing and try to sort his mind out. His mind is right now in a extremely jumbled and messy situation because of the diagnosis and other problems associated with it. If somebody can look at it from a distance and try to figure out that this is where the problem is, please sort it out this way. That is where we want help from you. So how do you go about doing this psychoeducation, and how do we tell patients that there is psychological support? It's not that you are alone here. There are people to help you out.
Right. See, the first thing about screening instrument, I'll just like to add one thing in that. There's something which is known as hospital anxiety depression scale. Now, why I'm mentioning it to you is that many of our patients who have depression and cancer have some kind of common symptoms, somatic symptoms, especially like, fatigue, tiredness, lethargy, reduced appetite, reduced sleep, and things like that. So, not to confound those things, these items on that list are actually deleted. And it focuses more on, your negative cognitions like worthlessness, feeling guilty about it. That is how we differentiate that this person is actually depressed, and it's not alone the somatic symptoms of the cancer that are manifesting as depression. That's about the screening instruments. Yes, there are others as well, but this is one thing that I wanted to highlight. Psychoeducation of patient, I think all of us do it in all our OPDs, all our clinicians, for patients who have either long-term or even short-term disorders, we ought to do psychoeducation. Psychoeducation should not be tried to be done in one go. I think it should be broken down into pieces and then told to the patient so that the patient understands it better along with the family. You help them in making the choices of the treatment that the patient wants to take up. It's not enforcing a treatment on the patient, but it's like letting the patient know what kind of choices I have, and then not acting very paternalistic about, you being a doctor and imposing things on that person. So that's about, what was your third question? I've forgotten, Dr. Chetan. About being referred to a psychiatrist, right? So probably in a situation like that, you can just tell the patient that, look, I think your problems seem to be beyond cancer. There's a lot of worry that I can see in your mind, for which I can only support you up to a limitation. And my limit is just this. And beyond that, I think you need to go and see a doctor who can probably help you out with these worries. You have a lot to talk about. I think you need to go and see another doctor for that. And I'm sure you will be helped out. So these are the usual things that, we do in psycho-oncological interventions. We take care of the emotional problems, the depression, anxiety bit, their physical problems like tiredness, pain, fatigue, with various interventions. I heard Dr. Mala mention it. I heard Dr. Komal Verma mention mindfulness-based activities that we do for pain, fatigue. Then, we also look at the social problems. I know we cannot solve it out for them, but then help them or assist them in looking at it in a different manner so that they don't start pitying themselves and the victimization thing comes down in them. Also, a lot of Indian patients are actually, linked onto spirituality and karma and, the meaning of life whenever they're diagnosed with illnesses like cancer. We should take help of that, probably living in India, and help them have a better quality of life. Also improvement in their general condition, like, advising them about their nutrition, lifestyle, all these things can be done. And like you were rightly pointing out, a patient who's probably depressed or psychologically disturbed would not adhere to treatment. So, optimization of treatment can only occur when a person is psychologically well. That is helped out because a depressed patient would not probably take care of self. They will have interpersonal problems with their family members. So decision making in the treatment process also gets affected in these patients. So these are the interventions that we do for pain and fatigue. There was a very nice meta-analysis recently published in 2021, and that has shown that things like mindfulness and hypnosis go a long way, and they have shown a significant improvement in pain in cancer patients. Relaxation and yoga also have shown positive results, but it's not been significant. Maybe further studies may show their significance as well. The other things that we use are mindfulness-based cognitive therapy and mindfulness-based stress reduction in the management of pain and fatigue mainly. Fatigue also we use, we optimize their energy levels and sometimes help them in just analyzing that when their energy levels are high, they have to do the work which is most prioritized by them. So that is how we go about doing mindfulness. Any kind of relaxation therapy has helped out in reducing the pain, nausea, and fatigue in cancer patients. So it could be, simple things like yoga, meditation, mindfulness-based activities, or even deep breathing, guided imagery. All these things help out in reduction of pain. There are other methods also that we actually use in cancer patients, especially in pediatric patients, in which we give them rewards if they go through the treatment process itself. So over a week, we reward them with a chocolate or things like that. Sometimes we make them, we find out which comic creatures they are fond of, a Superman telling them stories. So these are simple things which you can follow in in a day-to-day cancer ward, which can be done even by the by the nurses over there, the staff nurses. And the doctors don't even have to be involved in this entire process. Then there's something which is known as desensitization or systematic desensitization, in which we make the patient get rid of fears that are related to cancer treatment. For example, if a patient fears, some chemotherapy or, going to the room, we grade that fear in various stages. So he says that, I have 30% fear when I'm starting from home, which increases to 50% when I'm sitting in my vehicle, which goes up to 60% when I'm out on the door of the hospital, and it shoots up to 100% when I'm near the treatment room. In those cases, we help the patient go through the anxiety-provoking stimulus from the least anxiety-provoking stimulus. So, we remind them that today is your chemotherapy day and how you're feeling. Make them imagine it, then make them relax and get used to that state, thereby reducing their anxiety levels. So next, we take them up to the level of the hospital door and then to the treatment room. And then, we make them lie down on the bed. So it's done in a graded manner so that the patient ultimately gets rid of all the anxiety that he or she has for the treatment per se.
Just a minute to interrupt you here. Of course, systemic desensitization, I don't know how many of us can actually practice it, because most of our patients don't have that kind of luxury of time where they can allow themselves to get desensitized over a period of time. But going back to your earlier slides about pediatric patients, a child with cancer is a completely different ball game, because the child very often is oblivious to what is wrong with him or her. And the parents know everything about it, or they want to know everything about it, and they are stressed out. The child has physical pain, and parents have psychological pain. So how do you deal with this problem, that the child's pain, and in fact the child's pain, the moment the child is the child has to be poked for an IV line or for a blood collection, the mother starts crying, or the father gets upset, something like. So how do we deal with this situation?
So this is where we come to the caretaker's burden in any of these chronic illnesses. The caretaker burden is very, very high in anything, especially in cancer, especially the family members who are close to this person. And you can imagine a pediatric patient and the parents being extremely worried. This is one area which requires a lot of work, because ideally speaking, we have to take care of this, because this will ultimately become an impediment for us, whenever we are treating. Individual therapies, even group therapies can be done for these patients. For the supportive, for the caretakers of these patients. And it is mainly supportive therapy. So you just let them ventilate, what is wrong and what are the concerns that they have. It has to be done in a graded fashion. It cannot be done at one go. And there are a couple of studies from India itself in which they have found out that, the caretakers would want a better communication between the patient and the caretakers and the doctor itself. So sometimes we as doctors, we forget to think of a malignancy as only, we only consider it to be a lump. We don't think of the person and the circumstances that surround the person in totality. We need to look at it from that angle and then take it forward.
Yeah, absolutely. Caregivers are actually one of the most neglected community as far as a cancer patient is concerned. I'd just like to share with you a study which was done at Tata Memorial Hospital. I'm sure it has been done elsewhere as well, but then there was a list of symptoms which we had made for all those patients who get cancer-related symptoms. It started with nausea, vomiting, and fever and all that, and went up to even finding a parking space or finding a bed in the hospital, or the queues in the hospital, or the time spent in the hospital waiting for the doctor to see them. And we asked the patients, we asked their caregivers, and we asked their treating doctors to list these symptoms in the order of importance which they feel is important. And understandably, most patients said nausea, vomiting, mouth ulcers, alopecia. They listed them as primarily important. For caregivers, and this study was a big eye-opener for us in Tata Memorial Hospital, because caregivers listed financial burdens, loss of working time, and finding a bed or finding a parking space. These were more important to them than actual nausea or vomiting. And in oncologists, it was febrile neutropenia. Alopecia didn't even feature on their list, because for a cancer specialist, they felt that, well, if a person is doing well, eating well, and has normal counts and laboratory parameters, everything is fine. They don't need whether they have hair or not. It's anyway painless hair loss, so don't worry about it. And that is something which we need to realize, that caregivers, if they there are patient support groups, but caregiver support groups are not. I haven't seen any caregiver support group, at least in our side of the country. But we need to have supportive support groups of caregivers where they can probably vent out their feelings and discuss their problems and try to find out a solution for these people. So are there any professional caregivers, or are there any professional agencies which can help these caregivers? Any idea about that?
I don't think so. There are any professional agencies, but here in Bangalore, they do have some kind of support groups, okay, which are formed. I think this was actually because of a study that was done at NIMHANS. So they formed a support group for these caregivers, and that is how I'm aware of. But I think in all your hospitals, it's very easy because, when a patient comes to you for any radiation or chemotherapy, they come for a little longer duration of time. You can probably collect these caretakers and just hold a group session. One time, probably the medical staff themselves can address them, a psychologist could address them, or a nutritionist could address them, and solve out all their queries. It can be done just for half an hour, on a weekly basis. So it can be carried out every day. Obviously, all the patients don't come back to us every day. So on a weekly basis, at least, they'll have a rotation in which we'll get to see them every time. Also, there's a checklist which is known as concerns and coping checklist for cancer patients. So that also gives us a big idea about, what all things patients and their caregivers are actually concerned about, like you rightly pointed out.
I think we are towards the end of our presentation. Are we on time or are we overshooting our time?
I think we are over our time, sir. So.
Okay, I think so. Dr. Aarti, thank you. That was an excellent deliberation, and it gave us an idea as to what goes into our patient's mind, an area which is largely neglected. To conclude, cancer and psychological distress, they are at crossroads of various psychological and biological factors. Psychological well-being in patients with cancer is definitely important in recovery, and not only recovery, but even adhering to treatment, making sure that the treatment is done in the correct fashion and improving quality of life. We need to look into mind-body techniques like mindfulness, relaxation, hypnosis, and yoga, etc., to try and relieve some of the symptoms, because there are some symptoms for which we really don't have too many answers, but and our conventional therapies have given up as far as these symptoms are concerned. For the simple, to take a simple example like nausea, there is actually no great medicine for nausea. We are using antiemetics to treat nausea, but maybe these techniques can help us tackle this problem. And these are definitely areas which require further work. And of course, improving communication skills and trying to help the cancer caregivers and supporting them in some way is also need of the hour. Thank you. Thank you very much. Thank you, Dr. Aarti. That was an excellent presentation from your side. And I now hand it over to Dr. Varsha. Thank you.
Thank you, sir. Thank you, Dr. Chetan Deshmukh. Thank you, Dr. Aarti Bahal. It was a wonderful discussion.